All right, so we're going to discuss osteomyelitis now. All right, so this is what your bone looks like, normal bone, and this is what a bone with osteomyelitis will look like visually. And you can see like the infection here, and it's what it's looking like is attacking here into bone. So this is what it looks like on X-ray. This is what a normal bone looks like, and you can see here this blackened area is osteomyelitis of the bone. So with osteomyelitis, it's broken down into three different categories. So you have the hematogenous or endogenous, which is most common in children, and this is basically um, affected through the bloodstream. It's the result of infections that spread from another part of the body via the bloodstream, and it's caused by infection in soft tissues or joints or indirect inoculation. It, like I said, it's infection usually occurs at other locations, and mostly affects children. And the non-hematogenous or the exogenous, it's most common in adults. Um, so this is spread from a contaminated site, most commonly seen with direct contamination of bacteria, typically in open fractures or joint replacement surgery. Trauma to the bone or surgery. Trauma is the leading causative factor. Other causative factors are implanted surgical devices and puncture wounds. And then the contiguous osteomyelitis, most common in older adults. And these are skin infections that are spread to bone due to decubitus ulcers, affected total joint replacements, um, diabetic wounds, loss of protective sensation, autoimmune defenses, and most commonly are affecting the lower extremities in these patients. So, with osteomyelitis, when the bone tissue is infected, the bacteria induce an acute inflammatory reaction. The bacteria and the inflammation affect the periosteum and spread within the bone, causing bone necrosis. Um, Again, it can happen in children, all adults, older adults. Um, so that is the blood supply is then affected, causing segmental bone necrosis. It can be very painful for the patient. So it's classified again into three categories. You have an acute infection, which has been less than 2 weeks. You have a subacute, which is 2 weeks to 3 months, and then a chronic infection, which is longer than 3 months. Diagnostics of diabetes and/or foot puncture increases the risk of osteomyelitis by 30 to 40%. Associated with the following pathogens: Staphylococci, Streptococci, Enterococci, and anaerobes are the most common causative factors. So again, it begins with a process with an invasion of the bone and surrounding tissue by one or more bacterial pathogens, which leads to inflammation and increases in vascularity to the area, causing edema. A thrombus occurs in the vessel, which leads to ischemia and slow necrosis of the soft tissue and bone. Healing is delayed with necrotic bone, and infection most likely will occur. Staphylococcus aureus, Staphylococci, and aerobic gram-negative bacilli are the most common pathogens responsible. So this is what the initial infection looks like. This is periosteum. This is the initial site of infection. So you can get an abscess. This area is where blood supply, because of the thrombus, is blocked. And then this becomes, because there's not getting any blood supply, the tissue just starts to die. They can have a new piece of bone form, but this area is typically, if it gets too bad, they have to amputate. So once the dead bone is dead, there's no coming back from it. There's no blood supply. So they're going to have lots of pain, which is not relieved by rest. They're going to have swelling, tenderness, warmth at site. They can have systemic symptoms like fever, nausea, chills, malaise. They can have signs of chronic osteomyelitis, which is constant bone pain, edema, tenderness, erythema, and warmth at site. So initially when the patients come in, we're going to do white blood cells. They obviously will be increased due to infection. The ESR is the indicator for inflammation. The SED rate, that will be elevated. The CRP can indicate inflammation, normally elevated in the first 7 days of infection. Blood cultures will be positive. They can also have evidence of soft tissue edema, bone degeneration, positive periosteal elevation, which is enlarged bone due to pus formation. The pus formation, so like I showed you in this pocket here, this pus fistule, so this other, you can see this normal here, and because of this dead tissue and white blood cells are rushing to the area to fix it, this bone will kind of extra will form because of this pus. It's kind of try to treat itself. So you can see that extension there. So if it's chronic, they can x-ray of the area, but it may not show any deformity until about after 14 to 21 days. So a bone scan can be done for acute osteomyelitis when an x-ray is negative. It can be seen like 2 to 3 days after start of infection. They can also have a CT and MRI, but the gold standard for testing for definitive diagnosis is a bone biopsy. And they go in with a needle and they actually aspirate and take a biopsy of the bone to look at the cells to see what it shows and if there's an infection. So medical management, antibiotic therapy. So that's going to be based on the culture and sensitivity results, the patient's age, their kidney function, and their overall health status. While they are waiting for the culture and sensitivity, remember if they took a wound culture, it takes 72 hours. So instead of letting the infection spread, physicians usually place patients on a broad spectrum antibiotic that can be started until that wound culture results come back. Beta-lactam antibiotics such as penicillin and cephalosporin are typically the first line unless MRSA is suspected. If they are suspecting MRSA as the cause, then vancomycin is initiated treatment for these patients. We can give them opioids for pain. For diet, we want to have them increase their protein intake, which is going to help with wound healing. We want to have these patients decrease their carbs and increase vegetables, but definitely increase protein for wound healing. So surgical options for these patients, we can do surgical debridement and incision of the infected and or necrotic tissue and bone. This is like the last option that they want to do. First, they want to try to see if they can treat the patient with antibiotics. They don't, they will do this if there's an evidence of soft tissue abscess, if they suspect or there's a confirmed joint infection, if they have progressive neurological deficits or spinal instability, like with vertebral osteomyelitis, so that's osteomyelitis in your spinal column. In extreme cases, surgical amputation may be performed to promote healing and vascular supply to the bone proximal to the infection. So worst case, surgical amputation, but I have seen it done. I've seen it done in a gentleman's toes before he had them amputated because he had osteomyelitis in his foot. All right, so next up are urinary tract infections. So urinary tract includes the kidneys, the ureters, the urinary bladder, and their urethra. It's one of the most common bacterial infections in the world, accounting for almost 10 million healthcare visits. It's common in young women and older women. It's very unusual in men under the age of 50. The organism responsible for 85% of cases is E. coli, which is a common gram-negative bacteria. 5 to 15% are caused by Staphylococcus, which is a gram-positive organism. There's something called catheter-associated UTIs, or CAUTIs, are caused by gram-negative bacteria. Klebsiella and Proteus pseudomonas are some other ones. So risk factors. Occurs more frequently in females, and that is just because we have a shorter urinary tract. for females, and females ages 15 to 29, especially those over 65, are way more affected. It can be because of sexual activity, diabetics, patients have poor hygiene, estrogen deficiency, recent catheterization. All of these will increase a person's risk of developing a UTI. Also, incomplete bladder emptying, patients who have kidney or bladder stones. Um, if somebody has pelvic organ prolapse, those also increase your risk for UTI. CAUTIs, the catheter-associated UTI, are a significant cause of hospital-acquired infections, accounting for 40% of hospital-acquired infections. Like a preventative thing that women can do because they are at such high risk is urinate before and after intercourse, and wash perineal area before and after intercourse to help prevent UTIs from happening. So with men, they it's increased incidence in older men. So younger men, you don't really see it. UTIs happen. Again, back to this one, women over 65 are the most common affected. 15 to 29 are as well, but women over 65. This is deceiving here. So it's just saying here that with older men, they're at a higher risk than younger men. And that's due to enlarged prostate associated with cystitis. They can have increased risk of urinary stasis, chronic disease states like hypertrophy of the prostate gland, because that increases with age, impaired immune response. And then with women, older women, they can have like impedes of urine flow, incomplete bladder emptying, weakened perineal muscles. They can have a cystocele, which is a prolapsed bladder, or erectocele, which is a between the rectum and the vagina is an area, so that causes them to have a higher risk of having UTI. All right, so again, it occurs when bacteria enter the sterile bladder, causing inflammation. Most common entry point is through the urethra. Urinary tract normally sterile above urethra, but if the infection is isolated to lower UTI or bladder, it is cystitis. And if the infection involves the upper urinary tract or kidneys, it is called pyelonephritis. UTIs can be bacterial, fungal, viral, community acquired or healthcare acquired, acute or chronic. And again, females are a higher risk for developing UTI because of their short urethra, its close proximity of the vagina and the rectum. It allows vaginal and rectal flora to migrate to the urethra, causing a UTI. And male individuals are typically, again, less likely because of their longer urethra. It deters mitigation of bacteria to the bladder, unless they are older adults when they have the hypertrophy at the prostate. Because of that, it can cause them to have a higher instance. So older adults often present with nonspecific manifestations, can be like urinating more at night or incontinence. They can typically, in older adults, you're going to see just a slight behavior change and some confusion. That's usually the first indicator that maybe they have a UTI, especially in women. Lethargy, loss of appetite, just not feeling right. They may have fever or hypothermia. Cystitis is the most common, and remember, cystitis is isolated to the lower urinary tract or bladder, so that's considered cystitis. And pyelonephritis is the infection involves the upper urinary tract and kidneys. So that's in the renal pelvis and the parenchyma. From ascending infection, often asymptomatic, onset typically is rapid. Older adult presents differently, and it can be acute or chronic, but cystitis is more common. Cystitis is usually uncomplicated. It usually responds very well to treatment. Catheter-associated UTIs often can be asymptomatic. They most quickly resolve when the catheter is removed and then when a short course of antibiotics is started. And a lot of these patients that are in the hospital with Foley catheters, we need to weigh the benefits and risks before using an indwelling catheter, because having caudis are a real thing in the hospital environment, because there's so many organisms and germs that can get into the catheter. So some signs and symptoms: dysuria, which is painful urination. They can have urinary frequency, urgency. They can have feeling the urgency and need to urinate, but only having small amount of volume come out. They can have blood in their urine. They can have suprapubic pain. If it does become systemic, they can have fever, nausea, vomiting, and flank pain typically indicates that a kidney is involved. So some diagnostics for these, we're going to, based on their signs and symptoms, we're going to do a urinalysis and look at leukocytes, nitrites, hemoglobin, and bacteria. And then again, a CNS when it is a complicated UTI. So they'll do a culture and sensitivity of the urine to see what that is. Recurrent infections usually require additional testing. We can do an intravenous pyelogram, which assess renal blood flow and can diagnose tumors and kidney stones if they happen to be the cause of a recurrent infection. They can do a voiding cystourethrogram, which assesses flow of urine when voiding, a cystoscopy, which is a scope to assess the urinary tract, manual pelvic or prostate exam, renal and bladder ultrasound. On here, we also look at what white blood cells and red blood cells because of infectious and inflammatory responses. And also looking back at urinalysis, the nitrites, we will look at those. Some bacteria convert nitrate to nitrite, and they are what give that ammonia type smell. It'll go to ammonia, which will cause that ammonia smell in the urine to happen. So that is, again, nitrates in the urinalysis. So some treatment options for these patients: again, an uncomplicated lower UTI, a short course antibiotic therapy is typically all that is needed. Antibiotic selection is based on age of client, sensitivity, renal function, and their signs and symptoms. Short course therapy is pretty cheap, increases compliance because it's only for 7 to 10 days, and lowers the rate of side effects for patients. If it is pyelonephritis, so it's in the kidneys, there's some abnormality, there's kidney stones, it's usually a 7 to 10 day course. Ciprofloxacin is usually the one of choice for any type of UTI. Prophylactic antibiotic therapy if it's something that's like a recurrent thing. Some other, if it is severe enough UTI, they can also give IV antibiotics like ampicillin, gentamicin, or Rocephin. Sometimes it does require longer, like 2 or more weeks, if it is a very complicated UTI. Again, so then if they do have frequent symptomatic UTIs, they may be on prophylactic antibiotics like microdantin or macrobid, or urinary analgesics like pyridium. So I'll teach you guys about those meds in a few slides. So again, the most common bacteria associated with UTI is E. coli. The best treatment for this are anti-infectives of sulfonamide, which is Bactrim, nitrofuran, which is Macrobid, fluoroquinolones, which is ciprofloxacin, and aminopenicillins, which is like ampicillin. Those are the most common for treating E. coli. So sulfonamides examples are triamthroprim, sulfamethazole, or Bactrim Septra. Again, the reason they are given are anti-infective for bacterial, genourinary, GI, and respiratory infections. It is a broad spectrum gram-negative and gram-positive treatment. Hopefully the infection improves, white blood cells decrease, fever resolves, symptoms resolve. Some complications, unexpected outcomes are GI disturbances, tinnitus, dizziness, jaundice, tachyarrhythmias, stomatitis, and photosensitivity. Contraindications are any hypersensitivity to this med before, hepatic dysfunction, myasthenia gravis, cautions are renal impairment and liver impairment. And what we want to tell the patient is to monitor their infection, make sure that it is getting better, not worse, obtain specimens for culture and sensitivity before we start, monitor for side effects, and notify MD if there are any. Again, we need to monitor since it is affects their liver impairment, we need to look at their liver function test. We need to look at chest pain and palpitations, especially if they have any of the tachyarrhythmias, yellowing skin or eyes, again, because of liver impairment. Yeast infections can be a side effect of these GI or diarrhea. And then monitor eyes and nose, full glass of water. We want to take 1 hour before, 2 hours after meals, and make sure that they wear sunscreen and protective clothing, because the sun, they can make them more susceptible to getting sunburnt while they're on these meds. Nitrofurantoin examples are macrobid. Reason, again, UTIs, not really given if it's a systemic infection. Hopefully it decreases frequency, prevents UTIs. Complications are dizziness, headache, pneumonitis, GI symptoms, C. diff, rust-colored urine, photosensitivity, blood dyscrasias, and neuropathy. Contraindications are hypersensitivity and renal impairment. Cautions with diabetic or debilitated patients. Neuropathy may be more common. Elderly are at higher risk for renal, hepatic, and pulmonary reactions. Same kind of thing for these. Monitor eyes and nose, specific labs, pulmonary and renal function. Use sunscreen because of the photosensitivity. Inform patient that medication may cause a rust yellow to brown discoloration of their urine, which, that's just a big thing they need to be a warning of. It's common to happen. And then fluoroquinolones, so ciprofloxacin or Levaquin. Again, same thing. It can be given for UTIs, GI, and respiratory, like pneumonia. It is a broad spectrum, gram-negative and positive, or treats those. Hopefully the infection improves, white blood cells decrease, fever resolve, symptoms resolve. Complications, unexpected outcome, seizures, aortic aneurysms, or aortic dissection. They can have a rash, which is called Stevens-Johnson syndrome, which I will show you information about that in a little bit. Photosensitivity, hypoglycemia, hepatotoxicity, GI symptoms, C. diff, musculoskeletal pain and weakness, tendon rupture, and neuropathy. Contraindications are anytime they've had a hypersensitivity. If they have myasthenia gravis, which can cause weakness and issues with their breathing, and the abdominal aneurysm. Cautions, seizures, renal impairment, liver impairment, monitor for those. So we need to do CBC, glucose, since it can cause more issues with those types of patients. Liver functions, neuro changes, chest pain, palpitations, neuropathy, rash, yeast infections, GI symptoms, tendon pain. Again, take with a full glass of water. Take 1 hour before or 2 hours after meals. This one also can cause photosensitivity, so wear sunscreen. And tendon symptoms, avoid exercise and use of the affected area. Notify MD if they have any weakness. And then treatment and common bacteria. So if you have Enterobacter, nosocomial association with long hospital stay, prior use of antibiotics, underlying medical conditions such as diabetes, malignancies, and urinary catheters. So this is a common bacteria for those patients. Some pharmacologic treatment are cephalosporins like cefepime, fluoroquinolones like Cipro, Levaquin, and piperacillin tazobactam. And then treatment for Pseudomonas and Klebsiella pneumoniae are fluoroquinolones and like ciprofloxacin. The above bacteria are contagious. Patients should be placed on contact precautions because of these. The Pseudomonas is found in hospital environments and is contagious. Transmission is through contact with contaminated surfaces, and Klebsiella pneumoniae spread through person to person and requires also contact isolation. So there's another medication. This is not necessarily a treatment, but it's more of a helps with pain for the patients. So it's pyridium. It's a non-opioid analgesic. It is an analgesic that only affects the bladder. It can be used to decrease dysuria frequency and urgency. Expected outcome, it acts locally on urinary tract mucosa to produce analgesic effects. Warn the patient it will cause bright orange urine, and that can be an alarming thing for them, but it will help their symptoms of the UTI. Complications are hepatotoxicity, headaches, and vertigo. Contraindications are severe hepatitis, uremia, renal failure. Again, same kind of thing. Just make sure that we know that they have a bright orange urine. It can cause hepatotoxicity, renal failure, hemolytic anemia, headaches, vertigo. Contraindications, hypersensitivity, liver and renal impairment. So we need to monitor their renal and liver panels. Do not wear contacts because it can dye their contacts orange. So if they wear like long-term contact lenses, it can dye them orange. Take with food or milk. So their urine, their sweat, their saliva, their tears can turn orange. And again, it can stain fabrics and contacts. So some non-pharmacological treatment, fluids, drinking adequate fluids. You can give them cranberry and blueberry juice. Avoid fluids that irritate the bladder, such as caffeinated beverages, alcohol, and citrus fruits. They can also have herbal therapy like saw palmetto, and it's Palmetto. Some surgical options that we can do. It's indicated for patients who have recurrent UTIs, or if diagnostic testing indicates that they have kidney stones, structural abnormalities, strictures. They can have surgical options for those. So some may be stenting, a ureteral stent, which remains in place for 3 to 5 days, or it can be permanent, maintains patency and promotes healing of ureters, usually placed in renal pelvis. Monitor output, color, and bleeding for these patients, so urinary color and bleeding. And then some surgery indicated if recurrent UTI, if diagnostic tests indicate calculi, again, structure anomalies or strictures. There's percutaneous ultrasonic pyelolithotomy, which is removal of large kidney stones. They can have something called ureteroplasty. It's a surgical repair of the ureter. Structural abnormalities and strictures of the ureter. So prevention is one of the biggest things. Practice good personal hygiene, maintain generous fluid intake, empty bladder every 3 to 4 hours. Women need to make sure they cleanse from front to back, void and wash perineal area before and after sexual intercourse, maintain integrity of perineal tissue, maintain like acid in the urine. Fluid intake should be about 2 to 2.5 liters a day. And then maintain acid urine. So we need to make sure, like, drink cranberry juice, avoid vitamin C, avoid excess milk products, sodium bicarb, things like that, that can help make the urine more alkalonic.